They will have lethargy, fatigue, palpitation and breathlessness में कोई भी ऐसे symptoms हो सकते हैं.
न चैनं क्लेदयन्त्यापो न शोषयति मारुतः अच्छेद्योऽयमदाह्योऽयमक्लेद्यो शोष्य एव च नित्यः सर्वगतस्थाणुरचलोऽयं सनातनः.
Dear friends, greetings from the Medimedia people. We have seen, especially in the second wave, that a person infected with corona and then he becomes negative and died after some time because of post-COVID cardiac involvement. To understand this mystery, to overcome the misery of losing dear ones, let's hear Dr. Ripen Gupta, Director and Unit Head Cardiology at Max. Dr. B.B.Gupta, a senior family physician, will be interviewing Dr. Ripen. Over to you, Dr. B.B.Gupta.
I have the privilege of talking to Dr. Ripen Gupta. For me, for the last maybe 7 to 10 years, he's been looking after each and every one of my patients. And not only as a doctor, as a human being also, I can only speak nicely about him. I and Dr. Divakar were discussing few days back, and it was triggered by a fact that one of my patient who few days back, about 15 days back, he called me up कि सर मैं तो ठीक हो रहा हूँ कोविड से, मेरी वाइफ को पॉजिटिव हो गया है. मैंने कहा ठीक है आप एंड दीस डेज आई हैव बीन एडवाइजिंग कंसल्टेशन टू मेनी ऑफ माय पीपल ऑनलाइन पेशेंट्स. तो मैंने कहा ठीक है आपका तो सब ठीक है. हाँ जी मेरा ठीक है. एंड देन आई स्टार्टेड ट्रीटिंग हिज वाइफ. आफ्टर 4-5 डेज उसके ब्रदर ने मुझे फोन किया कि सर वो भाभी की तबीयत वैसे तो ठीक है लेकिन उनको वीकनेस बहुत हो रही है, जो अभी हम डिस्कस करते हैं, समथिंग लाइक दैट. एंड वो तो आपको पता ही होगा कि ब्रदर की डेथ हो गई. इट वाज सच अ शॉक एंड द वे ही मैटर ऑफ फैक्ट सेड दैट. मैंने कहा क्यों, वो तो ठीक थे. कहने हाँ वो रात में सोने गए थे, आपने बोला था कि चेकअप करा करो, रात में जरूर चेक कर लिया करो, ऑक्सीजन तो 98% थी और सुबह उठे ही नहीं. So that was the first time it clicked to me that it is not only the COVID virus we are dealing, it is also the other complications. So till now we were only focusing about the thrombus, about the anticoagulant therapy and the steroids and all that. So Dr. Ripen, I think you can tell us more about it.
POTS एक syndrome है सर, वो orthostatic tachycardia syndrome that is also increased after this COVID episodes. In India में हम उसको ignore कर देते हैं, जैसे patient का tachycardia हुआ post
anxiety हो रही है.
हाँ anxiety हो रही है वो कह देते हैं, वो सब POTS है basically. So ये POTS syndrome है, हम उसको इंडिया में diagnose नहीं करते properly, तो उसको हम उसी डस्टबिन में डाल देते हैं, मतलब ना एंग्जाइटी स्ट्रेस ये वो चलो, और एक आध मेडिसिन देके घर भेज देते हैं. Post acute COVID syndrome, and this is seen around 3/4 of patients who are on ventilator or hospitalized, and even up to 35% of the patients who are at home. This has been there because they say that the autonomic neurons also have ACE2 receptors. So once you have a COVID, they enter through this ACE2 receptor into those autonomic neurons and cause autonomic neuropathy, and which leads to POTS syndrome. So this POTS syndrome is one which we should look very carefully, and we should always look for the tachycardia part, and we have to then properly hydrate the patient and give him medications to bring the heart rate down. And also if the patient has postural hypotension, maybe give him mitodrain. This is a molecule to help the patient. Now coming to post-COVID part, that is very important because Dr. B.B. Gupta sir was telling about a case where a patient had a myocardial infarction. We have also seen cases. When we talk of COVID, we have to divide the COVID into mild, moderate, and severe, because cardiac manifestations will also depend upon the severity of COVID. So once we talk of mild COVID, that is when we monitor the patient at home, and most of them are treated at home, chances of these patients having serious cardiac complications are very less. We can have few patients where there is a fall in LV function, which could be a stress-induced cardiomyopathy, could be a myocarditis, which is happening during the infection, and these patients can have serious arrhythmias, like even ventricular ectopics, ventricular cardiac arrest can happen in these patients. Atrial arrhythmias are very common. And secondly, what we see in the sicker patients, even less sicker patient, is a fall in heart rate during they are having COVID. So that is another thing which is seen very commonly, that patient is COVID and his heart rate drops to 40, 45. We do an ECG, we find sinus bradycardia, there is no AV block. And this sinus bradycardia goes away in few days' time. So this is common during COVID infection. that troponin I elevation, which we see, will be more in hospitalized patients and especially patients who are in CCU. So again, the gradation is between CCU patients and non-CCU patients. All the complications we talk of, heart failure, arrhythmias, they increase by a factor of fourfold if the patient is in CCU, if the patient is on a ventilator. If the patient is in a CCU, even not on a ventilator, the complication rates are high. The troponin elevation is 1/4 of the patients who are admitted in a hospital in an ICU on a ventilator. Now, most of the times, this elevation of troponin is not a heart attack. This elevation is due to a secondary multi-organ involvement, which we see even in other conditions also. When we have a sepsis and all, we have a troponin I elevation, but there is no blockage. So this troponin elevation is part of the disease process. It does not indicate a blockage in the heart arteries. If this troponin elevation is there, it indicates poor prognosis. Higher is the value, poor is the prognosis of this patient. But this is not due to direct injury to the myocardium. This is due to a cytokine storm which causes the inflammation in all the organs of the body. The patient will have a deranged KFT also, deranged liver function also, and along with that, troponin is also elevated. And some will have incidental problems. So we cannot put those incidental problems as part of COVID treatment. Let's say I had a patient who had a COVID injection given, and next day he had a heart attack, and we did an angioplasty on him. He said, injection se ho gaya sir, mere ko COVID injection se. So COVID injection cannot trigger a heart attack. We all know the incidence of heart attacks during COVID is less. That the myocardial infarction is not huge, but the treatment is delayed during COVID pandemic. So we have more mortalities even in COVID negative patients. When he comes to us, also we'll do a rapid antigen test. There is a delay in the treatment. COVID pandemic heart attack patients are not treated as fast as possible. So maybe more complications are there, but COVID itself will not lead to a big, huge increase in number of infections. Post-COVID will have LV dysfunction, and they prior to COVID they have never had a heart dysfunction. Some form of dilated cardiomyopathy can be seen in few of the patients. Again, this will be seen in sicker patients, not patients who are stable, but patients who are very sick. So you have a patient who has totally recovered from COVID and now starts complaining of breathlessness. I think an ECG and an echo is must in those patients to look for any LV dysfunction which is there, and then we can treat accordingly. So COVID cannot be taken as an infection which will affect and go away. Now we know that once you have a COVID, at least like chikungunya fever had a lot of joint pains. Here we can have a lot of cardiopulmonary symptoms which may persist for many months after the COVID is over.
जैसे कि डॉक्टर रिपेन आपने 3-4 कंडीशन बताई, एक में जो है कि उसका ब्रेडिकार्डिया हो जाता है पेशेंट को, तो हम उसको कैसे मैनेज करेंगे? जस्ट हाइड्रेशन इंप्रूव करके एंड ऑल दैट।
सर ब्रेडिकार्डिया जो होता है ना, मोस्टली ड्यूरिंग कोविड इन्फेक्शन होता है। तो जब इन्फेक्शन खत्म होगी तो ये अपने आप ही खत्म हो जाता है 99% ऑफ द टाइम, एंड मोस्ट ऑफ टाइम दिस ब्रेडिकार्डिया ना विल रिजॉल्व ऑन इट्स ओन। हाँ, वी शुड ऑलवेज डू एन ईसीजी व्हेन द पेशेंट सेज कि मेरा हार्ट रेट 40 हो गया है। We should document by an ECG that it is a simple bradycardia. It is not a 2:1 block or complex AV blocks. Because if that is so, then we have to go for a temporary pacing also.
And the other side of the coin, if it is tachycardia.
So tachycardia during COVID will be in sicker patients who are on ventilator or who have a lot of respiratory distress. They are in ICU. So these patients usually we have to treat the underlying cause. We do an echo in these patients because they are having tachycardia. We want to rule out a LV dysfunction in this patient. But if the echo is also normal, then we say treat the underlying cause. And if the internist asks us to control the heart rate, then we usually give a ivabradine to these patients because the BP is always on the lower side because they are sick. So we don't want to cause a decrease in BP. So ivabradine is advised and that controls the heart rate. If you have a tachycardia post-COVID, so that may be part of POTS, or it can be an isolated phenomena also. Then we can give either beta blockers or ivabradine to control the heart rate. And I have seen that over the next couple of months, this goes away. So I always tell my patient that once your heart rate starts coming down, you can decrease the dose. And if it goes further down, then you meet me. I may stop it or I may continue with even a lower dose. And usually in 2-3 months time or even lesser time, it goes away. So I am not too much concerned. But if the patient has this tachycardia along with breathlessness, then I always will do an echo. I want to be sure that the patient has not developed a LV dysfunction or something, and tachycardia is part of heart failure, and I'm missing it and just treating it with the medicine. So then I like to, if the patient is just having palpitation, no breathlessness, no symptoms, he says, I go for a half an hour walk, 45 minutes walk, I have no breathlessness, then I may skip a echo also, and just to put him on a ivabradine or a beta blocker, and then he's fine.
And what about, can the steroids trigger any of these things?
So steroids can trigger, you talked about high blood pressure. So I've seen that steroids will cause a deterioration in diabetes control, plus it will cause a rise in blood pressure. So steroids cause sodium and water retention. So any steroid, especially when we give our routine steroids in high dose, they can cause sodium water retention, and that can cause hypertension. So this happens to most of the patients, and once we stop the steroids, in the next 7 to 10 days, the BP tends to become better. Pulmonary embolism. You see, pulmonary embolism is an under-recognized problem, and it can cause a sudden cardiac death also. So that is one thing which we miss a lot of times. So pulmonary embolism is one thing which is very common, and that is why we are now recommending that all the hospitalized patients who are in ICU should be on a LMWH regime, and once they are discharged, they should be on a oral anticoagulant for at least 1 month. Secondly, though venous thrombotic complications are very common in COVID, we can have arterial thrombosis also. So when you have arterial thrombosis, you can have sudden cardiac arrest. Signs of severe COVID, then we should always rush them to a hospital, get them admitted there rather than managing at home. So I think when a transition from mild to moderate should be understood by most of us, and we should be careful in managing those patients at home. Because sometimes we think that we can manage at home, and these patients are the ones who land up with a massive complication.
I always say that what we have studying in this on COVID, we have not even studied the whole for the graduation. It's such a concise reading which is going on, and every day it is changing. That is the biggest thing.
We are learning. So everyone has his own anecdotal experience.
Very rightly said, we are learning, and it is a very fruitful session where we have learned a lot of things. Thank you, Dr. Ripen. Thank you, Dr. B.B.Gupta, for putting up such a wonderful session. Thanks a lot once again.
Nice talking to you.
Haan ji, sir. Thank you, sir. Thank you, sir.
Thank you, Dr. Divakar. Bye, sir.